in this session, I will be discussing sickle cell anemia. So let's start sickle cell anemia. So I will be discussing the topic under following headings. Before starting sickle cell anemia, let me discuss the various types of human hemoglobins present in human body. So in hemoglobin, there are 4 globin chains. So in all 4 globin chains, always there are 2 alpha. So along with 2 alpha, if 2 beta chains are present, it's known as hemoglobin A. If along with 2 alpha 2 gamma are present, it's known as hemoglobin F. If along with 2 alpha 2 delta are present, it's known as hemoglobin A2. The concentration of hemoglobin A is 95 to 98% and it's the major hemoglobin in human body. The concentration of hemoglobin F is nearly 1% or less than 1%. The concentration of hemoglobin A2 is less than 3.5%. So these are the 3 types of hemoglobins along with their structure and their concentration in human body. So let's start hemoglobinopathies. So hemoglobinopathies are the disorders of the hemoglobin. There are 2 types of hemoglobinopathies, the qualitative and the quantitative. Now what is the difference between qualitative and quantitative? So let's discuss qualitative. In the qualitative disorders, the quality of the hemoglobin, actually the globin chain, is not normal, not good. So there is some structural abnormality in the synthesis of the globin or hemoglobin. The abnormality is in the structure, but its amount and quantity is normal. So the best example here is sickle cell syndrome that we are going to discuss in this session. So the second type of hemoglobinopathy is quantitative. Here the problem is in the quantity, the amount. Quantitatively, the hemoglobin or the globin is reduced or decreased in synthesis, although structurally it's normal. So the best example here is thalassemia. So there are 2 types of hemoglobinopathies, the qualitative, the quantitative. In qualitative, quality of globin is not good. There is some structural problem, structural abnormality. And in quantitative, the structure is normal, but it is reduced in amount or quantity. So these are the 2 types of hemoglobinopathies. So in this session, we are going to discuss sickle syndrome, which is a type of qualitative hemoglobinopathy. So sickle syndromes are autosomal recessive disorder. They are autosomal recessive disorder. Now here an abnormal hemoglobin is formed, which is known as hemoglobin S. I have told you there are 3 types of hemoglobin present in human adult body: hemoglobin A, hemoglobin A2 and hemoglobin F. But hemoglobin S is not a normal hemoglobin. It is found only in persons with sickle syndrome and it is an abnormal hemoglobin. So in these patients, abnormal hemoglobin S is present in the RBC, which leads to sickling of the RBC. Now what is the shape of normal RBC? It's biconcave because it is having hemoglobin A, the normal hemoglobin. But when hemoglobin A is replaced by hemoglobin S, so the shape of the RBC changes from biconcave to sickle shape, and this phenomenon is known as sickling of RBC. So that is the sickle syndrome. There are 3 types of sickle syndrome you have to understand. The first is the heterozygous. Heterozygous is there is 1 gene of hemoglobin A that is normal and 1 gene of hemoglobin S that is abnormal. So it is known as AS, and this is known as sickle cell trait. It's the trait, sickle cell trait. This is a heterozygous condition, very, very mild. The second is the homozygous condition in which both the genes are hemoglobin S. So there is total absence of hemoglobin A. The complete hemoglobin is hemoglobin S only, and this is known as sickle cell anemia. The first one was the sickle cell trait. This one is sickle cell anemia. And the third type is the double heterozygous state. It's the double heterozygous state. It's sickle C disease SC or sickle D disease SD. So these are the 3 forms. Now let me start with sickle cell anemia. So that is SS, the homozygous state. So the homozygous state of hemoglobin S in the RBC. Here there is 1 abnormal gene is inherited from each parent. It is an autosomal recessive condition. So one of the abnormal gene from one of the parent, the other abnormal gene from the other parent. Both the parents have one abnormal gene and both the parents have trait. But due to the homozygous condition, the child will have homozygous condition. The parents have the heterozygous condition and the child is having homozygous condition, that is sickle cell anemia. Now let me discuss the pathogenesis of sickle cell anemia. So in sickle cell anemia, there is problem in the gene which is coding for beta chain of hemoglobin. We know in adult hemoglobin A, there are 2 alpha chains and 2 beta chains. So in sickle cell anemia, there is no problem in alpha chain. Alpha chain is absolutely normal in structure, but there is some problem in beta chain. So where is the gene for beta chain? The gene for beta chain is present on chromosome number 11. So on chromosome number 11, in the beta chain gene, there is a point mutation. Now what is that point mutation? I would like to show you in this diagram. Can you see this diagram? In this diagram you can see this is the gene, this is the codon on the gene of the beta chain. Now the gene of the beta chain which is present on chromosome number 11, this is codon number 6. We know on the chromosome various codons are present which are triplet. This is the 6th number codon. So the 6th number codon is normally GAG. But here adenine is replaced by thymidine. So instead of GAG, it is GTG. So that is the point mutation taking place. So because of this point mutation, when it was GAG, it was coding for glutamic acid. But now it is replaced by GTG. A is replaced by T. Adenine is replaced by thymidine. Now it is coding for valine. So this one was hemoglobin A, the normal hemoglobin, but now this one is hemoglobin S. So there is change in only one amino acid, the 6th amino acid, because there is one point mutation at the 6th number codon. So at the 6th number codon, the exact mutation is that the adenine is replaced by thymidine. So at the 6th amino acid, it was normally glutamic acid and now it is replaced by valine. So you can learn like the mnemonic, glutamic acid is gone, G for G, it is gone, and valine is welcome, right? It is coming. So the glutamic acid is gone and the valine is welcome. You got my point? So because of this, the hemoglobin A is replaced by hemoglobin S. When it was hemoglobin A, it was dispersed throughout the RBC. So the shape of the RBC was biconcave. It was normal, circular, biconcave. But now the hemoglobin S, it is not dispersed. It will form elongated rods like this. To accommodate those elongated rods, the shape of the RBC changes from biconcave to sickle shape, and this is known as sickling. So you have to understand the pathogenesis of sickling if you want to understand sickle cell anemia. So this is the complete pathogenesis. So at the 6th codon, the 6th position at the gene, there is a point mutation which is known as missense mutation, which leads to glutamic acid replacement by valine, and hemoglobin A is replaced by hemoglobin S. So that is the complete pathogenesis we have seen. Now what are the consequences of sickling? Ultimately what is happening? The RBC, which is circular, biconcave, it is replaced by sickle shape. Now what is the problem in that? It will lead to 3 problems in human body. Number 1, it will lead to vaso-occlusion of the microcirculation of the capillaries. Number 1. Number 2, it will lead to hemolytic anemias. Number 2. And number 3, it will lead to increased MCHC, that is mean corpuscular hemoglobin concentration. I will be explaining you all 3. So let me start with the first one. So actually, when I have told you the biconcave RBC is converted into sickle shaped RBC, the shape is changing. So the sickle shaped RBC, this sickling takes place only when the hemoglobin is deoxygenated state. During oxygenated state, it is dispersed only. So there is a property in hemoglobin S. Ultimately, hemoglobin S is forming now. This hemoglobin S is abnormal hemoglobin. It's not normal. So hemoglobin A is normal. Hemoglobin A is always dispersed throughout the RBC. So it's like this. Inside the RBC, it is dispersed throughout, right? So hemoglobin S, what is the problem here? During oxygenated state, it's also dispersed like hemoglobin A. There is no problem during oxygenated state. But during deoxygenated state, now it form elongated rods. During deoxygenated state, it form elongated rods. To accommodate those elongated rods, the RBC will become sickle shape. So my point to explain you here is that during oxygenated state, the RBC is circular only, but during deoxygenated state, it converted into sickle shape. So this is the complete phenomenon. But so throughout the procedure, throughout the days, so oxygenated, deoxygenated state takes place. So the shape of the RBC changes from circular biconcave to sickle and vice versa again, repeatedly. But after multiple the cell membrane get damaged and RBC will become sickle shaped permanently. So at the initial start of the disease, the sickling is reversible. On oxygenation, you can reverse the sickling. But later on in the disease, once the cell membrane of the RBC is damaged permanently, the sickling become permanent. This is the point to understand here. Okay, let me move ahead then. Okay, so here you can see during deoxygenation of the hemoglobin S. During deoxygenation, there is polymerization of the hemoglobin S, which leads to formation of elongated rod-like polymers. To accommodate that, the shape of the RBC is disturbed and it will become sickle shape. And the phenomenon is known as sickling. Now, the problem is that the sickle-shaped RBC, let me draw a few sickle-shaped RBCs. So, these sickle-shaped RBC are very, very sticky. They are very abnormally sticky. They have high levels of adhesion molecules on their surface. So they stick with each other and they form clumps. They stick with each other, they form clumps, and because of the formation of the clumps, they cause occlusion in the microcirculation. Let me show you in the diagram. Can you see this diagram? In this diagram, appreciate, this is biconcave circular RBC, they don't stick with each other. So they are flowing freely. Unrestricted blood flow is there when they are flowing inside the microcirculation. But when RBC becomes sickle shaped during deoxygenated state like this, so they are very sticky. So can you see here, appreciate the clump, they are sticking to each other and they are forming the clump. They have high levels of adhesion molecule. So they are blocking the microcirculation and this is causing the vasoocclusion. So this is how vasoocclusion takes place. Now let me proceed ahead. Now with repeated episodes of deoxygenation and sickling again. So during oxygenated state it is normal, but during deoxygenated state it's sickle shaped. So due to repeated episode of this again the membrane damages permanently and the RBC becomes sickle shaped permanently. Permanently it becomes sickle shaped. So when such abnormal sickle shaped RBC passes through the splenic sinusoids, the spleen recognizes that this is an abnormal RBC and it causes phagocytosis of the spleen. It causes sequestration and phagocytosis of that particular abnormal RBC. So that particular abnormal sickle shaped RBC undergo hemolysis. Since the hemolysis takes place in the spleen, not in the blood vessel, it's extravascular hemolysis and which leads to hemolytic anemia. So here patient presents with all the symptoms of the anemia like fatigue, So there is fatigue, lethargy, lack of energy. So that is the thing. Here you can see in this diagram, you can appreciate here, this is a splenic sinusoid inside which you can appreciate this is a sickle shaped RBC going and it will be sequestered and phagocytosized. You can see here also, this is the sickle shaped RBC going inside the sinusoid of the spleen. That is the second problem. Now the third problem is that when the membrane of sickle shaped RBC is damaged, so water comes out, it will lead to intracellular dehydration and it will lead to increased mean corpuscular hemoglobin concentration. Let me draw. When the RBC was biconcave sickle shaped, it was having adequate water. So the hemoglobin was dispersed throughout. But when RBC becomes sickle shaped, the membrane is damaged. Since the membrane is damaged, the water leaks out. Since the water leaks out, there is intracellular dehydration. Now the same amount of hemoglobin is compacted in a lesser water. So the concentration increased. That's why MCHC is increased. I hope you got it. So these are the three problems which takes place in sickling or sickle cell anemia. So you got the pathogenesis. You can see the same thing here. You can see in this diagram it is shown this is hemoglobin A. This is GAG and the adenine is replaced by thymidine. So GAG is replaced by GTG in the DNA. So hemoglobin A is replaced by hemoglobin S. When hemoglobin A is replaced by hemoglobin S, what will happen inside the RBC? Initially, whenever there is oxygenated state, it's biconcave only. But whenever there is deoxygenated state, it will convert into sickling. So sickling is reversible initially, but the sickle shaped RBC are sticky. That's why they cause microvascular occlusion. But later on, the sickling become permanent because the cell membrane is damaged. It is permanent and such sickle shaped RBC are removed or phagocytosized by the splenic phagocytes and it will lead to extravascular hemolysis. So basically the two end results are microvascular occlusion and anemia. These are the two end results you can say. So these are the two end results. Let me teach you the factors determining the sickling. There are 5 factors which determining sickling. We will be discussing them one by one. The first factor, let me discuss these. You can see the 5 factors are enumerated here. I am not reading them. I will be explaining you the 5 factors one by one. So the first factor here responsible for the sickling is the amount of hemoglobin S. Number 1, how much hemoglobin S is present in the human blood and interaction with other hemoglobins. Either other hemoglobins are present or not present. If they are present, what is the interaction of hemoglobin S on other hemoglobins or what is the impact of other hemoglobins on hemoglobin S. So that is the thing. Now, if there is a homozygous individual, that is SS, so only hemoglobin is hemoglobin S. 100% hemoglobin is hemoglobin S only and no other hemoglobin is present, right, in homozygous condition, that is SS. That is the most severe sickling. So here sickling takes place directly. We can say sickling is directly proportional to hemoglobin S. More is the hemoglobin S, more is the sickling. We can understand that. But in heterozygous condition, only 40% of the hemoglobin is hemoglobin S. The remaining 60% of the hemoglobin is hemoglobin A. And the point is that hemoglobin A have an inhibitory effect on hemoglobin S. So more is the hemoglobin A, less is the sickling, you can say, right? Because here out of 100, only 40% is hemoglobin S. So sickling will be only 40%, not 100%. But in fetal hemoglobin, you know, when a newborn is taking birth, the hemoglobin, the predominant hemoglobin in the newborn is fetal hemoglobin for the first 6 months of life. And after first 6 months of life, the hemoglobin F is replaced by the adult hemoglobin A. You got my point? Hemoglobin F also have inhibitory effect on hemoglobin S. So whenever a newborn with sickle cell anemia is born, in the first 6 months the newborn don't have any symptoms. This is the reason. It's very important MCQ. As soon as the newborn is taking birth, so the hemoglobin in that newborn is hemoglobin F, and hemoglobin F is having inhibitory effect on hemoglobin S. So sickling will not take place or less takes place. So the newborn will not face any symptoms till 6 months of age. After 6 months, when the hemoglobin is replaced by adult hemoglobin, then the fetus or the newborn will have symptoms. The second criteria or second factor determining sickling is hemoglobin concentration of the RBC, that is MCHC, mean corpuscular hemoglobin concentration. It is directly proportional to sickling. More is the MCHC, more is the sickling. Less is the MCHC, less is the sickling. And MCHC depends on the intracellular dehydration. So greater is the MCHC, greater is the sickling. The third point is the intracellular dehydration. How much water is present inside the RBC? More water will be present now, so concentration of hemoglobin will be less. MCHC will less, so sickling is less. But if less water is present here, so MCHC will be more. The concentration will be more and sickling will be more. So you understood the intracellular dehydration. The next point to be understood here is the pH, effect of pH. When the pH of the blood is less, that is acidic pH or acidosis is there in the blood. Acidosis causes reduced affinity of the hemoglobin for the oxygen. So whenever the oxygen have reduced affinity for the oxygen, hemoglobin have reduced affinity for the oxygen, that is, it leads to deoxygenated state of the hemoglobin. Whenever the hemoglobin is deoxygenated, it will facilitate sickling. So basically acidosis is directly proportional to sickling, you can learn like that. More is the acidosis, less is the pH, more is the sickling. This is the conclusion. Now the fifth and the last factor is the length of the time for which the low oxygen tension is exposed. The cells are exposed to low oxygen tension. So there are two types of organs in human body. The organs which have fast blood flow and the organs which have slow and sluggish blood flow. So all the organs which have slow and sluggish blood flow, like bone, like spleen, here the exposure of the cell will be for longer time to the low oxygen tension in deoxygenated state, because here the blood flow is very slow and sluggish. So there is high chances of sickling in these organs. So faster is the blood flow, less is the sickling. Slower is the blood flow or sluggish is the blood flow, more is the sickling. That is the point. That is the end result. You got it? So moving ahead, let me teach you the clinical features of sickle cell anemia. In sickle cell anemia, there are two clinical features, the anemia and the vaso-occlusive phenomenon. So we have already discussed them. Anemia occurs when there is irreversible sickling takes place. So initially the sickling is reversible, but after some time the membrane of the RBC is permanently damaged, so RBC undergoes sickling permanently. Here at this point, when the sickling is permanent, they are removed, they are sequestered and they are phagocytosed by the splenic macrophages. So the RBC is undergoing extravascular hemolysis that will lead to anemia. So patient presents with the symptoms of anemia along with jaundice, along with reticulocytosis. And the second symptom here is vaso-occlusive phenomenon. So as I have told you, initially the sickling is reversible. So on oxygenation, it's normal. On deoxygenation, sickling takes place. So when sickling takes place during deoxygenated state, it is having high level of adhesion molecules on them. So they are very, very sticky. They just stick to each other, they just form the clumps and they occlude the capillaries. So vaso-occlusive symptoms are the most common manifestation in sickle cell anemia in the initial stages. Now can you tell me the name of the organs in which this vaso-occlusive phenomenon is taking place? What are the name of the organs? Most commonly it takes place in the bone. It can lead to hand-foot syndrome. especially in the digits. Can you see here in this diagram the digits, the fingers, the digits of this child, right? It is having end arteries. And whenever these end arteries are blocked by sticky clumps of the sickle shape, they got inflamed. It's highly painful condition. This is known as hand-foot syndrome. Sometimes in the femoral head, there is avascular necrosis. The cheek bone become prominent. Can you see here the child with a prominent cheek bone and the mole occlusion of the jaw? It is because the compensatory phenomenon in the bone marrow here in the maxillary bone, in the cheekbone, it is trying to compensate by doing erythroid hyperplasia. So because of the compensation, the marrow cavity is expanding and it is leading to prominent cheekbones. So looking at the face, you can make out the child is having sickle cell anemia. You can get a clue. The same occurs with the skull bone. Along with maxillary bone, it occurs with the skull bone also. There is crew cut appearance. Can you see here the skull bone? Appreciate the skull bone. Appreciate the widened marrow cavity here. Please appreciate. And it is known as crew cut appearance. In the vertebra also the same thing is happening, which leads to fish mouth appearance of the vertebra. Can you see here? The diagram is not put here. The vertebra, the shape of the vertebra is like this. It's looking like fish mouth. The shape of the vertebra become like this. Again, because of the expansion of the bone marrow. So it is fish mouth appearance of the vertebra, right? So these are the symptoms related to the bone, related to the bones, right? Apart from bones, the vaso-occlusive phenomenon also takes place in the lung, which leads to acute chest syndrome, which is characterized by cough, fever, chest pain, right? Apart from which, there is vaso-occlusive phenomenon in the brain, which leads to seizure and stroke. There is vaso-occlusive phenomenon in the skin, which leads to leg ulcer. There is vaso-occlusive phenomenon in the penis, which leads to stagnation in the corpora cavernosa, leads to priapism. There is vaso-occlusive phenomenon in the leads to aplastic crisis also because of parvovirus B19 infection. And spleen have a special role here. The spleen is having a special role here. Now, in the initial stages, there is splenomegaly. As I have told you, when the sickling become irreversible, the cell membrane of the RBC is damaged permanently. When such sickle-shaped RBC passes from the spleen is causing phagocytosis of those RBC and causing extravascular hemolysis. So, the size of the spleen increases. It is known as splenomegaly in the initial stage. But later on, due to prolonged hypoxia, prolonged vaso-occlusive phenomenon, spleen undergo autosplenectomy. You can see the diagram. This is autosplenectomy typically taking place in sickle cell anemia. It's a very important MCQ repeatedly asked in the exam. You can see here. Now the next point is that there is protection against the falciparum malaria. There is protection against. Now there is a special property. All the persons with sickle cell anemia, they are protected against the malaria. So there is one advantage of having sickle cell anemia. Why these persons are protected against falciparum malaria? We know malaria is also of 4 types. So it's vivax, Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale and Plasmodium malariae. Out of the 4 types, it is protected against the falciparum. So what is the point here? So all the patients with hemoglobin S, they are relatively protected against the falciparum malaria because the malarial parasite consume oxygen. So imagine a RBC. Let me draw RBC. Inside this RBC, you can see this is the parasite. This is the Plasmodium falciparum parasite. It resides inside the RBC. So it is consuming all the oxygen. Once it consumes all the oxygen, it will cause deoxygenated state. In deoxygenated state, it will promote sickling. So this RBC convert into sickle shaped. The RBC having the parasite. The RBC having the parasite will get converted to sickle shape because the parasite is consuming the oxygen, right? Now this sickle shaped RBC will be sequestered in the spleen. It will be phagocytosed in the spleen. So such RBC is killed. Along with the RBC, the parasite, Plasmodium falciparum parasite is also phagocytosized. So the parasite load is down. So they are protected against, in this way they are protected against the falciparum malaria. You have to learn that. Now let me talk about the screening test and the confirmatory test, right? So screening test. As I have told you initially, at the initial stage, the sickling is reversible, right? So just suppose this is a test tube, you are taking the blood sample of a patient in which you have suspicion the patient has sickle cell anemia, but the patient is in oxygenated state. So at oxygenated state, you can't find sickling here. You cannot find sickling here. So artificially, we will create a condition in which there is deoxygenated state is created. So how would you do that? Take the blood sample of the patient and mix with sodium metabisulfite. It is a reducing agent. When you mix the blood sample with sodium metabisulfite, it will create the deoxygenated state, right? Now, if the person is normal, person don't have any sickle cell anemia, so even on deoxygenated state, the shape of the RBC will remain circular only, the test is negative. But if the person is having sickle cell anemia, so on adding reducing agent, it will create deoxygenated state and they undergo sickling. So on adding sodium metabisulfite, just prepare the peripheral smear and do microscopy. On microscopy, if you find still the shape is circular, the person is normal, the test is negative. But on adding sodium metabisulfite, if the shape is changing to sickle shaped, so it is considered as sickle cell anemia and this is considered as a positive test. But this test is a screening test by adding reducing agent. Learn the name of the reducing agent, it's sodium metabisulfite, right? Now coming on the diagnosis. For diagnosis, the first thing, look at the peripheral smear. In the peripheral smear, you will find sickle shaped cells, target cells and Haemoglobin bodies. Let me show you here. You can see these cells are sickle shaped cells. Can you appreciate? All these cells are sickle. Here also you can appreciate. These all cells are sickle shaped cells. These all cells. So you can find sickle shaped cells. You can find target cells. You can find Haemoglobin bodies. This is a Haemoglobin body, please appreciate it. An inclusion body in the RBC. Here also you can see the target cells. So on peripheral smear, these are the findings. Let's talk about ESR. Here ESR is reduced, right? ESR is usually increased in all anemia except sickle cell anemia where ESR is reduced because there is no Rowlex formation here. There is no Rowlex formation, so ESR is decreased here. The most important diagnostic test, the confirmatory test is electrophoresis. Do electrophoresis. Can you see here the 3 electrophoresis bands are there? You can see the electrophoresis band. If it is a normal person, let me show you. In the normal person, you will find only one band, that is hemoglobin A. This band is of hemoglobin A. But a person with sickle cell trait have 50 or you can say 60% of the hemoglobin as hemoglobin A and only 40% of the hemoglobin is hemoglobin S. So you will find the two bands in hemoglobin in sickle cell trait. But in sickle cell anemia, the 100% hemoglobin is hemoglobin S. So you can find whether you are finding one band or two band. If you are finding two bands, of course it's a case of sickle cell trait. But if you are finding one band, you have to see the band is of hemoglobin A or hemoglobin S. So that will decide, that can differentiate the sickle cell anemia from sickle cell trait. So we understood that in sickle cell anemia, it's one band. And in sickle cell carrier or trait, it's two band. Right. Now, how to differentiate the one band is of hemoglobin S or hemoglobin A? So, basically hemoglobin S moves slowly towards the anode and hemoglobin A moves faster towards the anode. So, in this diagram also you can appreciate here, this is hemoglobin A, it is moving fast towards the anode, and this is hemoglobin S, this one is slow, this one is slow. So, looking at the band, you can identify this band is hemoglobin A or hemoglobin S. And if you are finding both, of course, it's a carrier, it's a trait. So that is the best way to diagnose, that is hemoglobin electrophoresis. So that's all about sickle cell anemia. I hope you have learned the topic well. We have seen the pathogenesis, the clinical features, the lab diagnosis, the screening test, the confirmatory test, all about it. Let's solve some MCQs based on this concept. The first question is in front of you. In sickle cell anemia, the defect is in which chain? So, in hemoglobin we are having 4 chains, 2 of alpha, 2 of beta. So, there is a defect in alpha chain or beta chain or both or none. So, of course, there is a defect of beta chain. In the beta chain, the chromosome of the beta chain is 11th chromosome. On 11th chromosome, the gene of the beta chain, the 6 codon, you know the exact defect. The adenine is replaced by thymidine, leading to replacement of glutamic acid by valine. So, correct answer here is beta chain. It's a very common MCQ repeated in the exam. Coming on the next question, sickle cell mutation. So, of course, sickle cell mutation is a point mutation. So, in which adenine is replaced by thymidine. So, it's a point mutation, we all know that. Again, most commonly asked question. The third question is in front of you. Person having heterozygous sickle cell trait. Use the word here, the word used is heterozygous. Sickle cell trait is protected against which infection? The person is protected against Plasmodium falciparum infection or Plasmodium vivax infection or Pneumococcus infection or Salmonella infection. So, we all know that sickle cell trait are protected against falciparum, malaria, right? We know the reason also because here the parasite load is kept low by causing sequestration of the RBCs in the spleen. So correct answer here is falciparum. We know that. The next question is in front of you. Autosplenectomy is seen in. So we know the autosplenectomy seen in sickle cell anemia. So in initial stages there is splenomegaly, but in later on the spleen size is reduced because of constant hypoxia. Right. So correct answer here is sickle cell anemia. Right. The next question is in front of you. In sickle cell trait, can you tell me the number of bands found on hemoglobin electrophoresis? So we have seen hemoglobin electrophoresis in trait. There are 2 bands. 60% is hemoglobin A and 40% is hemoglobin S. So there are 2 bands. So the correct answer here is 2. You can appreciate the same here also. Appreciate the 2 bands. They are asking in trait. See the question again. They are asking in trait. So in trait 2 bands are there. But if I am changing the question, instead of trait I am asking in sickle cell anemia, the correct answer will become 1. Here in sickle cell anemia we get only 1 band. So please mind your question. In your exam, the question is about sickle cell trait or sickle cell anemia, because answer is differing about in both of them. The next question is in front of you. In sickle cell anemia, what is true? Read the 4 statement. Which one of them is true? Autosplenectomy due to thrombosis or infarction? Yes, autosplenectomy takes place. Microcytosis? No. Microcardia? No. Splenomegaly? No. Initially splenomegaly takes place, but later on it's autosplenectomy. So the best answer to go with autosplenectomy. Right. So that's all about it. I hope you have learned the topic well, sickle cell anemia. So thank you.